Thank you so much, Dr. Doval, and I thank Team Mylan for giving me this opportunity to moderate this panel discussion. I think I will share my screen from here. I think somebody will have to unshare the screen from that side. Yeah, pardon. Can you see my slide? Can you see my slide?
Very much we can see, Dr. Ashok.
Oh, excellent. And I've sort of given it a caption of TNBC 2020, and we are almost coming to the close of the year. I thought we will have a discussion on some of the burning topics, and since we are running a little ahead of time, it gives us a little extra headroom to engage in some discussions about the TNBC and look at the various aspects of it. We have a very busy panel here. Dr. Thomas, I understand, probably may not be able to join. Dr. Poonam Patil from Bengaluru is...
Sir, Dr. Boben is there.
There? Oh, yes. Good. So my apologies. So Dr. Boben is there. Dr. Poonam Patil from Bengaluru, Dr. Dubey from Delhi, Dr. Sarin from Chandigarh, Joydeep from Kolkata, Deepak Gupta from Jaipur, AVS Suresh, Hyderabad, Krupa, Shankar, Coimbatore, Amit, Jetani, Rajkot, Ravi, Wategaonkar, Pune, and Madhuchanda Kar from Kolkata, and I'm Ashok Vaid, your moderator. So we pretty much have
Sir, just Dr. Vaid, just to inform a couple of things. Dr. Dubey, Dr. Wategaonkar are not there, and Dr. Joydeep. Three are not there. Other are there. Vikas Asati is also there.
So good news for the rest of the panelists. They will have more questions and more.
And Dr. Nilesh Lokeshwar is also there from Mumbai.
So we have a pretty much good sort of a national integration and happening out here, and let's go ahead. So some of just the basics of TNBC that from the Western literature we know that it's about 15%, and we are finding in a little trifle above about 20% and 20 to 23%. Some of the centers reporting like that, and generally thought to be chemo responsive, and with the new research in the metastatic setting and in the neoadjuvant setting, now the paradigm is moving, and we have new drugs and new concepts which have come in. For the metastatic disease, where does the recurrence happen? Look at the triple negatives versus the luminal, and the HER2 versus the luminals. And there is some degree of similarity, brain versus others, and similar for the HER2. And one can see that the lung, brain, and they are the two major areas versus bone and liver, which are less frequent. So these are the two major areas which are of concern. So I think let's get on to the discussion per se, and with the ladies first, I would invite Dr. Poonam Patil to be the first panelist on board to tell us something about the molecular subtyping and the clinical relevance of the subtyping. Do we in today's time choose any treatment based on the molecular subtyping or not? And we just heard about the AR signaling and the relevance of the anti-AR drugs. So Dr. Poonam, over to you for alluding to this.
Thank you very much for letting me be the opening batsman. As we heard earlier, Dr. Satish talking about the histopathological importance of breast cancer. Certainly in triple negative, the histopathology doesn't depict much, but it's the molecular subtyping which is very important in triple negative breast cancers. And it is many times the genetic profiling and the gene profile signature that determines the type of triple negative breast cancer. I can see you've put a very lovely slide, but yes, if you look at the normal anatomy, there is a lumen, there's a basal membrane, and then there are mesenchymal cells. So it's very easy to remember that there are luminal androgen receptor type, the mesenchymal type, which is divided into two, mesenchymal and mesenchymal stem cell like, the basal like 1, basal like 2, and the other subtype which is heavily infiltrated with the immune cells. So you have these 6 basic types: basal like 1, basal like 2, immunomodulatory, mesenchymal stem cell like, luminal androgen receptor type, and the mesenchymal epithelial transition type. So these are the main types of triple negative breast cancer. And yes, as the importance is to see.
Yeah, just a word about the differential response to neoadjuvant chemotherapy.
Yeah, so we heard Dr. Cortis and Dr. Satish both talking about the responses to neoadjuvant chemotherapy and the pathological complete remission, which is a surrogate for the prognosis. So this is where this differential response is important. The basal like 1 is something which is most responsive to neoadjuvant chemotherapy, and the luminal androgen receptor type, which is probably akin to the ER positive types, which are not so responsive to chemo but are responsive to hormone therapy. The same way here, the basal like 1 is more responsive to chemotherapy, and the luminal androgen receptor is the least responsive. Also, the drugs that are used, the basal like responds to taxanes, it responds to cyclophosphamide, and also to anthracyclines, whereas the mesenchymal type doesn't respond so well to taxanes and all. Anthracyclines, it responds better. So there is also some differentiation in the treatment profile. The basal like 1 also responds to cisplatin and carboplatin, the platinum source.
Excellent. Thank you, Dr. Poonam, for that wonderful exposition on that. And we move on to the first, the neoadjuvant segment, and about the neoadjuvant chemotherapy. The next panelist I would request and would be Dr. Madhuchanda. Above, to tell everybody on the program here about your rational threshold size of the tumor, because it's always a dilemma in the clinic. But where do you put your threshold size? The surgeons are always itching to operate, and the medical oncologists are wanting to sort of give neoadjuvant therapy. So where do you, in your practice, put the threshold of the tumor size and the residual cancer burden once you have given neoadjuvant therapy? Dr. Madhu. Dr. Madhu, are you there?
She has to unmute. Dr. Madhuchanda, you have to unmute. We can't hear you.
Dr. Madhu, you need to unmute yourself.
Yeah. I think I'm unmuted. Just see.
Yes, now you have.
Okay.
Very well, very well.
So, TNBC or any other tumor, we usually have a tumor board to decide that whether we will go for a neoadjuvant chemotherapy. And I think there are impending and proved data that obtaining a PCR will help us prognosticate these tumors regarding their distant recurrence or progression-free survival. So most of the tumors in our practice, if they land up in the oncology department before getting operated, we do give them neoadjuvant chemotherapy for TNBC tumors. And then we look into the PCR.
Your comments about the PCR, the importance of PCR.
Pardon?
Yeah, your comments about the importance of PCR.
Yes, we know, as from your beautiful slide, we can see that the importance of PCR is really great, because at the end of the therapy, if we get PCR, we do find that the overall survival and the relapse-free survival, the event-free survival, all these are improved if we have a PCR. And in our neoadjuvant chemotherapy, we use both anthracyclines and taxanes.
So you have brought up a very pertinent question here. You hear about the use of anthracycline taxane. Are you using as a combination or you are using as a sequential?
No, not as a combination. We are using sequential.
So I open this question to the other panelists here. Anybody who's using a combination of anthracycline taxanes upfront, or everybody is using now as a sequential? So probably I take this as a yes to sequential.
Most of us are using it as sequential rather than combining it with other anthracyclines.
But a few years back, Dr. Vaid, we were very enthusiastic on combination, to tell you frankly. So but that practice has changed.
So Dr. Cortes, your comment. And could we request Dr. Cortes to offer his comment on the sequential versus the combination? Any current usage of a combination anymore?
So I think that in general, because we have the opportunity to use sequential regimens, we prefer sequential regimens in the neoadjuvant setting always. In the metastatic disease, if we do so, we do with Avastin. So no, in general, we do not use combination of anthracyclines and taxanes.
Excellent. Let's now get on to the issue about the residual cancer burden, and we know that the residual cancer burden does influence the outcome of the disease. And if you do, Dr. Cortes, if you do have a significant residual cancer burden, the patient comes back with a YPT1 and 1 or something like that. Do you go by the CreateX type of a route, or do you go for the next line of whatever radiation or whatever is lined up for the patient?
Yeah, that's an excellent question. We usually continue with the CreateX schema, and we offer capecitabine for 8 cycles for patients with non-PCR and triple-negative breast cancer. We do not offer for ER positive, but we do for triple-negative. Yes.
The rest of the panelists, if a quick comment could come from the other panelists about the CreateX type of approach. I invite it's an open invitation. It could be taken up by any one of the panelists.
I also agree with that thing. If the patient has got residual disease left behind after a full cycle of neoadjuvant therapy, definitely the patient will merit from the addition of capecitabine. So I also continue for 6 to 8 cycles depending upon the tolerability of the patient.
Can I make a comment? I'm sorry. No, yeah. So I mean, like of late, sir, we've also been started using this oral metronomic capecitabine for 1 year, low dose of capecitabine, 625 milligrams metaspire BD. Because that's based on the recent ASCO update. We have the Chinese study, the CIS-UCC study, which has actually shown an improvement in DFS as well. So 1 year of maintenance capecitabine is something that we use for patients who have residual disease as well. So it's irrespective of the residual disease. Anybody's TNBC right now, we have switched over to actually giving them 1 year of maintenance of metronomic capecitabine.
So I have an associated question with that. Where do you bring your radiation then? So how do you sequence your radiation when you're getting?
I think you complete the radiation and then you consider the adjuvant capecitabine. And I think a larger challenge is, like Dr. Krupa Shankar mentioned, which dose do you really choose? Do you use the CreateX of 2,500 milligram per meter square, or the GCAM study, which is a little lower dose of 2,000 per meter square for 6 months? Or do you use the SUSSC study, which is given 625 mg BD, but for a whole year? I think in practice, the lower dose metronomic schedule probably suits our patients better, because we know that hardly any of our patients can really take a 2,500 milligram dose for 6 months. It's quite toxic, and the quality of life again is a big issue in this situation. But I definitely think that this is one way of dose escalating or escalating therapy in patients who have not achieved the path CR. And consistent studies have shown that this approach improves the overall survival.
I think that's a very valid point. Let's move on. And another question is about the use of taxanes in the neoadjuvant setting. If Dr. Boben could pick up this.
Yeah, thanks. Yeah, definitely taxanes has got a significant role in the management of all kinds of breast cancer. So we have discussed earlier, like all of us are using taxanes and most of us are using it right now in the sequential format. So as you can see over here, 26, the amount of complete pathological response following a neoadjuvant taxanes when it was added to to the AC regimen, the PCR rate significantly improved. The issue with this, whether it was to go for the weekly paclitaxel or go for the 3 weekly paclitaxel, or should be taxanes, or should we go for the NAP paclitaxel, that was the issue. And that has been answered to at least to some extent by the GPR Scepter trial, where patients were randomized either to conventional paclitaxel or to the NAP paclitaxel. Next slide, can you change this? Yeah. As you can see, when on changing the regimen from paclitaxel to NAP paclitaxel, there was an improvement in the progress in the pathological complete response rate from 29% to 38%. Next slide. So the disease-free survival, yes, there was an advantage for NAP paclitaxel over conventional paclitaxel. Next slide. And when it comes to subgroup analysis, even in triple negative breast cancer, there was a significant difference rather than in the hormone positive and HER2 negative breast cancer. Next slide. But for overall survival, there was not much of a statistically significant difference was not there, but numerically, yes, there was a difference. So definitely, yes, taxanes have a significant role, and of the taxanes, then now we have started using NAP paclitaxel because of the tolerability format. So to summarize everything, this effect shows that in all subgroups, especially in patients with triple negative subgroup, definitely the addition of taxanes, especially NAP paclitaxel, has got a significant improvement in the disease-free survival. So a weekly NAP paclitaxel dose of 150 milligram per meter square is so. But then the rate of sensory neuropathy is a little bit higher. But nowadays we know how to manage it. So we need to be really cautious about this neurotoxicity part. Thank you.
Excellent. I think that was very well summarized, and taxanes continue to hold a significant role. The question about paclitaxel versus NAB paclitaxel, and Dr. Dubey, I understand, is not on the panel. He's not able to join, and I couldn't catch the name. If somebody could help me, from Mumbai, I understand, has joined the panel. Somebody from the organizing team could help.
I'm here. I'm Nilesh Lokesh from Mumbai, sir.
Go ahead with that then. Then this question is all yours.
So I think most of the newer trials are now using NAP paclitaxel along with carboplatin as a combination therapy for neoadjuvant therapy. So, well, I'm not aware of this study per se, but I do know that NAP paclitaxel gives a higher rate of pathological state.
And one could see from this trial, the PTNA trial, that the PAT-CR for NAP paclitaxel was higher. So I come back to Dr. Cortes once again. In your practice, how often are you using NAP paclitaxel, or have you switched over to NAP paclitaxel, or you're still with the paclitaxel?
Yeah, so that's a very good question as well. So in Spain in general, or in Europe outside Germany, NAP paclitaxel is not widely used in the neoadjuvant setting. I have used it a lot, but in my opinion, the role of platinum compounds in combination with taxane is key, is important. So unfortunately, we do not have strong data about the combination of NAP paclitaxel plus platinum compounds. Then I use platinum compounds and paclitaxel. If by any reason I cannot use platinum compounds, then I prefer to use NAP paclitaxel than using paclitaxel. I don't like the ETNA study. I prefer the Jaipur study much more. Because in the ETNA, the control arm was paclitaxel 3 weeks on, 1 week off. And the same with NAP paclitaxel, 3 weeks on, 1 week off. And in my opinion, this is not the preferred regimen in the neoadjuvant or in the adjuvant settings.
Excellent. I think that's a very valid point. Dr. Doval, I'm not supposed to be dragging you into the panel discussion, but I can't resist that, because I remember the two trials, the Abraxane, ABI 00102, both the low dose and the high dose, many years back. And how's your practice spread out or panned out over the years between paclitaxel versus nab-paclitaxel? Anyway, let's move on. I think probably he couldn't. Now, Jatin, Dr. Cortes just mentioned about the role of platinums in the neoadjuvant management. Now, this is a very important and a pertinent subject, and we would want you to allude to this topic and tell us about the quickly and in a nutshell the role of platinums and how important they are.
Well, sir, the role of platinum, as you have clearly mentioned in your slides, have been pretty controversial, but everyone is tempted to use this in a triple negative breast cancer, especially the basal-like breast cancer, primarily because it helps in achieving more of PAT-CR. You know, PAT-CR in triple negative has been considered kind of a holy grail to achieve good results, and that's where these days even immunotherapy has been combined in neoadjuvant settings. So definitely strong results as far as achieving PAT-CR is concerned, but it doesn't translate into increase in overall survival, and also it leads to more of side effects. So again, raises a very important and pertinent question, which I really want to ask if our esteemed faculty from Spain can answer that how important is PAT-CR as such in triple negative breast cancer, and why we are chasing PAT-CR specifically when sometimes even by achieving PAT-CR, we are not achieving increased overall survival.
Dr. Cortes, that's a question to you from Dr. Sarin.
Dr. Sarin, I think is a great comment. So from an individual perspective, I think that achieving PCR is clearly important. We have plenty of data showing that the patients who achieve PCR have better disease-free survival and overall survival curves. That's very clear. From a trial perspective, we have recently published a manuscript in Cancer Research saying that in TNBC, this is also true from a trial perspective. So the more PCR, the better long-term outcomes. There is a correlation also with the hazard ratio in clinical studies. The point is that in the past, there were so many differences in treatment options, in the adjuvant, that in my opinion it's difficult to make to do these correlations. But again, from a patient perspective, it's very clear. If you achieve PCR, more probability to be cured. From a trial perspective, we need more data, although some recently published go in the same direction.
Right. Thank you, sir. The other thing is, in the metastatic setting, we have seen in one of those studies that there is hardly any difference if you use taxane, especially docetaxel versus carboplatin. So a contradictory thing as compared to those in early breast cancer. So, but again, in BRCA positive, platins score a point, and yes, they could be used.
No, I have this slide summarizes the trials, and most of them are in the phase 2, except the Octo and the trials.
It's actually the meta-analysis of this trial, and this all shows that yes, the PAT-CR is improved with addition of platin, and we are tempted to use platin in whichever patient suitable we can use. It's like that.
So, Dr. Kotis, your comment on this forest plot, this is like a summary sort of the PCR versus the platinum-free controls in all the patients. And we see that the increase in the PAT-CR from 37 to 52%. Again, the debate remains that though we are getting a clear sort of answer from this, but why is it not translating into the overall survival benefit?
Well, there are two randomized phase 2 studies that has shown the correlation between the adding platinum compounds and disease-free survival. One of them is the Jaipur, the German study once again, that has shown an improvement in disease-free survival and overall survival. And the other one is the CLGB. We should not forget that in the CLGB, it was a 2x2 clinical trial design, and also Avastin was explored there. So there were some patients, 50% of patients who received platinum compounds that also received Avastin, and the other way around. There were 50% of patients who did not receive carboplatin that did receive Avastin. So I don't know how to interpret this data with two confounding variables there. In my opinion, the strongest data of platinum compounds and long-term outcomes come from the Jaipur study, from the German study, and it correlates with disease-free survival. So I don't think that we can say that it does not translate into an improvement in DFS.
So excellent. I think I have a couple of slides to sort of come back to, and Nilesh, could you take up this? Are there any special considerations? Is platinum for everyone in the neoadjuvant setting, or is it for some special groups like the couple of slides I have brought up here about the or any other subgroups where you think that it's.
So just to summarize what everybody just spoken of late, that while platinums have shown to improve the incidence of PAT-CR, it has not translated into OS benefit, and therefore it's probably not for all. But we have trials where there's combination of either platinum alone or platinum with velaparib or talazoparib or the platinums again in the neoadjuvant setting. And what it seems is that patients who have germline BRCA mutations, these are the patients who will definitely have an advantage and an improvement in the response. And this is a group of patients where I will definitely consider adding carboplatin as part of my neoadjuvant therapy. And I will not do it for each and every patient. Another situation where I might consider using neoadjuvant platinum is in the situation where the patient has a locally advanced breast cancer, which is primarily inoperable, not for early breast cancers. So these are the two subgroups where I feel that there is enough justification for the addition of carboplatin to the chemotherapy backbone.
And do you agree that stage 1 tumors with comorbidities should not receive the platinum?
I agree.
Excellent. So, excellent. Let's move on now.
Sir, can I just make a small point, sir? I know we've always been talking about the role of platinums as far as increasing the PAT-CR is concerned, but are there any takers for actually reverse sequencing where you start off with taxanes and then anthracyclines? The reverse sequencing also seems to translate into a better PAT-CR as well. We have data for that based on the NeoSamba study and also Indian data, especially from CMC Vellore, where they've looked at dose-dense DC and EP, which is docetaxel cyclophosphamide followed by pirubicin and cisplatin and dose-dense chemotherapy, which is Indian data as well. And they have also shown a PAT-CR rate of around 58% that they presented at ESMO 2020 as well. So any takers for that, where you start off with taxanes and then anthracyclines, and the reverse sequencing could also show an improvement in PAT-CR?
So my apologies, there were a couple of slides because in the interest of time, I thought I had hidden those. And maybe I'm bringing some of the reverse sequencing in the metastatic setting. So let's move on to the treatment options and BEV and platinums. Joydeep, particularly only about, is there a role still for BEV and platinums in the metastatic TNBC? Joydeep, are you?
Dr. Joydeep, in place of Dr. Joydeep, Dr. Vikas is also there.
So, Dr. Vikas, then you could take up this question.
Yes, sir. So the role of bevacizumab in metastatic breast cancer, especially the TNBC, there is benefit, especially with response and also with PFS. But it has not turned into increase in the overall survival. So that I will discuss with the patient, and if the affordability is not an issue, I will definitely use the bevacizumab.
Any comments from other panelists about this use of BEV, and how many are using BEV in TNBC in the metastatic setting?
So again, I'm not very inclined towards using bevacizumab because I think it's not an approved option as of right now. Because I mean, like the guidelines might endorse it, but as if you're talking about it as an approval, I don't think it's approved as of yet for the treatment of triple negative breast cancers. I think there was an interim approval, but then the FDA revoked its stand on that, and the approval for TNBC stands cancelled as far as bevacizumab is concerned.
Okay, do you use BEV upfront?
So I might probably reserve its use for a later line of therapy, not as a first option in metastatic.
Fair enough. Fair enough. I think the about the platinums, your comment about the platinums. You talked about the BEV, but could you offer your comments about it? Anyway, so let's move on to the next segment, because I can look at the watch and say that we still have about 15 minutes to go, and we could complete all this. Now, targeting the DNA damage and response defects, Dr. Deepak. So your take on the PARP inhibitors. We were just talking about the PARP inhibitors in the neoadjuvant setting. What about the metastatic setting, and the rationale and your take on this? Mira, is there a connection issue, or what's happened?
No, all the panelists are there, sir.
But I can't find Deepak Gupta. Who's taking in place of Deepak? Anybody could take up this, the fastest finger first.
So, Deepak, can you unmute yourself?
I can't see.
So I'll take that. I'll take that question, sir. So you're probably referring to the role of PARP inhibitors and its approval in metastatic triple negative breast cancers. Well, we have 3 studies: the EMBRACA study, and basically we have talazoparib, and then we have olaparib, which has been approved, and also veliparib, this is based on the Brocade study. What is interesting is all of these have shown only a PFS benefit, apart from the Brocade study, which looked at it in combination with pacli and carboplatin as well. So, and despite not allowing for crossover, none of these trials, especially the olaparib study and the talazoparib, did not show a statistically significant overall survival benefit. So it was only a PFS benefit of around close to 3 months, with no overall survival, despite not allowing for crossover, and also prior platinum was only allowed in 18% of those patients. So majority of the patients did not receive prior platinum, and the treatment of physician's choice did not allow for a platinum also. It was only, there are randomized only versus eribulin, capecitabine, and minorelbin, did not include a platinum. I think these were the criticisms of the PARP inhibitors, the studies with PARP inhibitors. So yeah, agreed, PFS benefit, but again, no overall survival benefit despite not allowing for crossover. So definitely not an option in the first line. Maybe in the subsequent lines, if somebody's got a germline BRCA mutated, yes, you would want to offer it.
And despite getting better overall responses.
Sir, can I add one thing?
Please.
There was an interesting study of cisplatin with veliparib, and it was shown in that study that, in fact, the BRCA-like phenotype fared much better as compared to germline BRCA mutated phenotype cancers. So that was enigma kind of a thing.
So, Dr. Portis, your usage of the PARP inhibitors, in your practice? Where do they come? At what point in time in the metastatic setting?
Yeah, no, yes, we are using them. Usually in second line or beyond. In first line setting is not that easy. The point is that I think that the activity these compounds have is very, very similar to platinum compounds, but it is true that the quality of life seems to be better. So yeah, I think they are nice agents, clearly interesting to be used. Both talazoparib and olaparib are approved in Europe, and yes, I use them, but in second line or beyond, not in the first line setting.
Not in the third line. Okay, so let's move on to the immunomodulation. No discussion on any of the solid tumors today is complete without discussion about the immune checkpoint inhibitors. And for all this important discussion, I invite Dr. Suresh, AVS Suresh, to offer his comments. We have heard very elegant presentation by Dr. Kotis about the various trials, and let's sort of recap all that, and very quickly in a capsule form, Dr. Suresh, if you could tell us about the.
I think we had a very elaborate discussion on the immunotherapy, so well presented. So probably my job will be just to shortly conclude and then just see what we can do in India. So just to, if I have to just summarize in a few bullet points, number one, the sooner you use, that is the earlier you use, the better are the response rates. The later you use, lesser are the response rates. That's one of the very important things with the immunotherapy that we see in the breast cancer, unlike and very similar to the other trends also. The number two, very important is they can go along hand in hand with most of the chemotherapy agents without having much of decrement. Okay, so the two active agents, that is atezolizumab as well as pembrolizumab, there is no much big difference when they have used it in the neoadjuvant setting. But they didn't add any significant value in terms of PFS and OS. So still, I don't consider either of the studies as practice changing, and we are not yet there to use them. So probably in my practice in the neoadjuvant, I will be using only the bladder cancer, which is not relevant for today's discussion. So that's a short 5-point bullet summary of immune checkpoint inhibitors in TNBC, especially for the early cancers.
Very, very, very well put. Now, we'll just dwell on the 522 study for a moment, and one can see that this is one of the positive studies in the early TNBC.
How many? You can just go to the next slide, sir. I mean, the data is there. And just
yeah. So how many of the panelists believe that this is going to change the practice? Tomorrow morning, you're going to treat the next patient on this type of rationale. Suresh,
not me, sir. Not me, our friend.
Not in a neoadjuvant setting.
Not me, sir.
None.
Well, the point, let me make a comment about this. So the point here is that this is a very expensive drug, okay? So because we have very, very similar data that with platinum compounds, for example, and we use platinum compounds. Why? Because it is quite cheap. So I think that these data are strong. Look at the event-free survival. I know that this is not mature there yet, but look at the data. It seems very promising with a very improvement in PCR. So I agree that it is not ready to Monday morning, but I think that here we have also a price problem, in my opinion at least.
I think all of us on the panel would agree with you. This is something beyond the reach of majority of us. Any comments from the panel on that?
Dr. Vaid, is it because of the cost that we have this third block at the moment? Otherwise, the results are looking quite positive and exciting.
The cost is the major constraint, ma'am, because Dr. Ashok told that can you use it on Monday morning? Probably then a lot of people have to arrange money for that.
Yes, so I think it's the cost ultimately.
Yeah, absolutely.
I think everywhere in the world.
Yeah, so rightly said, Dr. Ashok.
Of course, it is true that you said before, I think it's very important. The long-term outcome data are still very immature. So we just have the PCR. So I think that it's all together, you know. So we need the mature data to definitely move forward into the immunotherapy field in the neoadjuvant setting. But I think that cost budget will be also a very important barrier for a broadly use of these agents, in my opinion.
So I think it's a cost versus benefit ratio. I mean, for the same amount of benefit to be achieved for a larger population, this amount of cost is not justified, I think.
So right.
How many months you would prolong, or how many lives you would actually save? I think that's
5 to 6% survival advantage for a cost of 30 lakhs. I have my reservations, at least in India, sir.
Everybody would agree with you. So let's move on and talk about the
androgens.
We are signaling and something which has been around for quite some time. The trials have not been very exciting. Dr. Krupa Shankar, need your inputs on this. We heard from Dr. Cortes also, and still we tend to use this as a one of the therapies when we fail and then we don't have much to use. We resort to the AR inhibiting drugs.
So yeah, as you rightly put up there, sir, I think the luminal subtype is where you have the maximum amount of androgen expression, and there's also in apocrine breast cancers, where you almost always have the androgen receptor expression in apocrine breast cancers as well. And then there's this new entity called quadruple negative breast cancer as well, where the AR is also negative. All 4 of them are negative as well. But as far as targeting the androgen receptor is concerned, we have only phase 2 data, early data, single arm data only, be it with bicalutamide, enzalutamide, or abiraterone. So we still don't have level 3 or level 1 or phase 3 evidence for using these androgen receptor antagonists. But having said that, it's a clinically unmet need. So somebody who's progressed on multiple lines, and if the androgen receptor is strongly positive, you would still want to contemplate using enzalutamide or abiraterone, enzalutamide preferably. So and that's how I would look at targeting the androgen receptor. We routinely do an IHC only to look for the androgen receptor. Just like how we do a ERPR on HER2, we check for the androgen receptor on IHC only. I mean, that's what is being done at our institute. We don't use the genomic testing. We only use the IHC for androgen receptor.
Interestingly,
is it acceptable, Dr. Shankar? How is your results, sir?
Sorry, hello.
How are your results, Dr. Shankar?
Yeah, so
IHC, is it correlating well? Because I heard that IHC is not a truly sensitive marker to predict the response to the enzalutamide and calcium.
See, the thing is, basically, there will be no studies looking at the concordance between gene expression profiling versus IHC. So we're not sure about the concordance rates, but what we have seen is around 15 to 20%. I'm talking about total TNBCs of what we have done until now have turned out to be AR positive, and we've probably used androgen receptor antagonists on 5 patients until now. And out of which we've had at least only 2 people who've responded until now, and the other 3 have not responded at all.
That's 40% is a great number.
Yeah, but that's about it. But and 5 is too small a number for for us to draw conclusions on. So we really need to have much more larger numbers before we actually draw conclusions.
My apologies, gentlemen. We are coming to the close, very close to the final. But I take the liberty of extending it by about 5 minutes because we have a couple of points. As I said, we would talk about TNBC 2020. So we don't want to some of the points. PI3K, AKT, mTOR pathway in TNBC. Dr. Amit, your comments about this important emerging area of interest in TNBC.
I think PI3K and mTOR pathway we usually target in hormone receptor positive breast cancer, and no approved therapy for triple negative breast cancer to target PI3K inhibitor or mTOR pathway.
So I've brought there is some data, some research which is on, and this is on the untreated metastatic TNBC, paclitaxel plus the pan-AKT inhibitor versus paclitaxel. Any comments about anybody has an experience of having used the PIK3? Dr. Cortes, any experience with PIK3 inhibitor?
Well, I think that both AKT inhibitors, capivasertib from AstraZeneca and ipasasertib from Roche, have shown very similar data in triple-negative breast cancer in combination with paclitaxel in the first-line setting. So both drugs are in randomized phase 3 studies in these triple-negative breast cancer first-line cohorts. So I think that there is a clear potential improvement in the long-term outcomes for patients with the pathway altered. So I think that I like it, but I think that we need these phase 3 studies before moving forward in the clinical practice.
Thank you so much. And another trial in the triple negative from one of the other drugs, and then one can see the overall survival in the intent to treat population slightly favoring the experimental arm. And based on the P10 expression, some data which is emerging, probably these are early days, and then we would only learn out of that. And Dr. Ravi is not on the panel. So ADC, I think we'll skip that. We have heard from you, Dr. Cortes, very elegantly, and then we would move on to some biomarkers, newer biomarkers. There is a slide up here, and since Dr. Dubey is not on the panel, anybody could take up this for his or her comments, and then before we sort of decide to close the discussion, I think this is probably one of the last slides I've put up out here. Anybody would like to offer any comments about the emerging biomarkers?
Make a brief comment. So I think that this is a beautiful slide for the future, what is coming in the future. Today, in my opinion, what we need for triple-negative breast cancer is PD-L1, maybe microsatellite instability, and BRCA1 and BRCA2. Unfortunately, all the other aspects will be upcoming. We will present at San Antonio also very beautiful data this year about the TROP2 expression and the activity of sacituzumab. But in the time being, just BRCA, the instability for pembrolizumab, and PD-L1. This is all we need, in my opinion.
Thank you so much for that summary statement on the subject. And then we move on. I think we would not get our dinner till we don't talk about eribulin. I think we've already heard about all this, so we would skip probably talking about eribulin. We have heard about the EMT, about the other factors why the drug works so well in the triple negative segment. And in the interest of time, we would skip this and I think move on to the last part of the presentation. Can we simplify the metastatic TNBC algorithm? I think we began with the ladies first, and I request the ladies to close the discussion out here once again. Dr. Poonam, Dr. Madhu, please come on unmute yourself and talk about something, though this looks a little sort of, I would say, bit futuristic, bit practical, and still something which is the state of the art as on 2020. So
I think Dr. Cortes has so well pointed out that at the moment, the two most important things which we can look into is the PD-L1 as per the Ventana platform and the germline BRCA mutation as per approved assay. So if we can look into these two, then the chances that PD-L1, according to this slide, if we look into it, we'll have an expected percentage in our practice of around 40%. I have no personal data, so I can only share this data. BRCA will be around 15%, and there is a subset where both can be positive, 7.5%. So these two remain the most important biomarkers already that has been discussed. And we have something new in the metastatic setting, that is atezolizumab and nab-paclitaxel as the first line in PD-L1 positive subset. We had good discussion on PARP inhibitors, whether it's the prime time to use it, and carboplatin. We talked about the early breast cancer also, but we are now limiting this slide to metastatic breast cancer. And we all heard that we can reuse taxane, re-challenge with taxane. There is a subset, there are evidence that bevacizumab improves PFS, but no benefit on the overall survival. I don't know how many of us are using bevacizumab. Personally, I'm not using it. And then we have so many other combinations which we can use with bevacizumab. We have single agents, particularly for today, eribulin is a drug which has shown overall survival benefit. Capecitabine is very easy to handle, but difficult in the approved dosage schedule. We all have modified our own dosage schedule.
Madhu, could I request Poonam to
Yes. So Dr. Poonam, can you take?
Yeah, now this is what we can do as of now, but I think Dr. Vaid, you showed one slide where there were biomarkers and the treatment that could go along with those biomarkers a few slides back. I think that is the futuristic slide, and this is what slide you showed just now. Yeah, this slide is probably the one that we can do practically as of now. But to say futuristic may not be 2020, maybe 2021 or 2022. That is what we are going to look at, where we have the biomarkers and the corresponding therapy against those biomarkers.
Thank you so much. And with that, I have the privilege of offering some of the conclusions. And all that I would say is that this disease entity is now become a group of diseases in itself, and there are breakthrough genomic and molecular data which is emerging, and the landscape for triple negative is also going to get more crowded and getting more complex. But ultimately, it's the benefit to the patients which is of paramount importance. Thank you, everyone on the panel. My profound thanks to Dr. Cortes for joining the panel, and my thanks to all the panelists who have done such a wonderful job and given us such clear, crisp comments and led the discussion so beautifully. Thank you so much, and I thank Mylan for this opportunity, and my sincere thanks to my mentor, Dr. Doval, for giving me this opportunity. Thanks once again.